Hey guys, welcome to my video on Cushing syndrome and disease. I'm going to start out by reminding you to please subscribe and turn notifications on. So when we talk about Cushing syndrome, there are three basic things that we need to understand. How the hypothalamic pituitary adrenal axis works and how negative feedback works. How we suspect Cushing's in a patient and how do we diagnose it. And also easy ways to remember diagnostic test results for each pathology. So I'm including helpful ways to know these without thinking too much, especially in a stressful situation. So how do we get too much cortisol? So excess cortisol could just be stress, obesity, or exogenous administration. It could also be primary organ neoplasm. So when we talk about cortisol, the primary organ is the adrenal gland. There could also be a secondary cause, so that is that our pituitary is secreting too much ACTH, and that's because of something called a pituitary adenoma. The last cause is a paraneoplastic syndrome. So paraneoplastic syndrome is when a lung, usually when in the lung, there is a tumor, and usually that is a small cell lung cancer, secretes ACTH ectopically. So that's what we call an ectopic ACTH producing tumor, because it's producing ACTH outside of the pituitary. Remember also that lung is not the only place where ACTH is secreted in a paraneoplastic syndrome. A paraneoplastic syndrome can arise from a tumor in the ovary, for example, but lung is the most common organ. When we talk about the hypothalamic pituitary adrenal axis, the way it works is that the hypothalamus secretes a releasing hormone, which stimulates the anterior pituitary to secrete ACTH. ACTH binds to the adrenal gland and stimulates it to secrete cortisol. The cortisol binds to virtually every kind of tissue in the body, and it does so by binding glucocorticoid receptors. So here are some examples: binds to blood vessels, adipose tissue, bone. And the real take-home point here is that excess cortisol, if in the system, has a negative effect on how the hypothalamus secretes the releasing hormone, as well as how the anterior pituitary secretes ACTH. So this is what we call a negative feedback loop. Now, some applications of our knowledge of the feedback loop tell us that if the excess cortisol is indeed caused by a pituitary adenoma, feedback control will be partially retained. However, if because of the excess cortisol is a lesion outside the pituitary, feedback control is almost completely lost. So I'm going to now talk about the clinical presentations of Cushing syndrome. So an extreme clinical presentation would be a truncally obese person with purple striae and buffalo hump neck. But that's kind of extreme. The more typical presentation would be a patient with increased abdominal girth, with borderline or elevated HbA1c, elevated blood pressure, and a female, menstrual irregularities. So this is an overview of how we would go from symptomatology to trying to figure out and confirm our suspicions. So the first thing you do is confirm the presence of overproduction of hormone. The second is confirm location or etiology of overproduction through suppression and secondary hormone levels. And the third is use imaging to visualize overgrowth in cells. And remember, in endocrine disorders, you always do imaging last. 24-hour urine cortisol is the gold standard. If the 24-hour urine cortisol is negative, the patient definitely does not have a Cushing syndrome. You can move on. But if the 24-hour urine cortisol is positive, you're going to want to do more tests. high-dose dexamethasone suppression test is a test where a large dose of dexamethasone is administered in the patient and the serum cortisol is measured overnight. If there is at least a 50%, if there is more than a 50% drop in the serum cortisol, that is considered a response to suppression, and that means some feedback is still present. So that tells you the lesion is in the pituitary. And that points to a Cushing's disease. So a Cushing's disease is a pituitary adenoma that is causing excess cortisol. It is a true Cushing's disease only if there is a pituitary adenoma. So if the suppression test has a response, you're going to do an MRI pituitary to confirm. If the high-dose dexamethasone suppression test does not meet the adequate response, the lesion is not in the pituitary. And you know that because there's no the feedback regulation is not evident. ACTH levels help you see that excess or elevated ACTH is indicative of pituitary adenoma or ectopic ACTH producing tumor. A low ACTH indicates an adrenal pathology. So just to recap what I have said about these tests, for pituitary adenoma, METH suppresses the brain. So that means dexamethasone is suppressed if the lesion is in the pituitary. So I like to remember it by METH suppresses the brain. Ectopic tumor. I like to call it ACTOpic tumor because ACTH is elevated. So that's when you have a tumor, usually from the lung, that's causing a paraneoplastic syndrome secreting ectopic ACTH. Adrenal neoplasia, so adrenal is drained of ACTH. That's how I like to remember it. So I don't have to think too much. What is low, what is elevated, it just comes right to me. And I want to point out one more thing. I mentioned that imaging is important as the last step. So in the case of if you have a high dose dexamethasone suppression test that has an adequate response and you have elevated ACTH levels, you're going to think pituitary adenoma. So you do the MRI pituitary and it's equivocal. So what do? You're going to do something called an inferior petrosal sinus sampling. Another thing is, if you have a lack of response to the high-dose dexamethasone suppression test and an elevated ACTH, you're going to do a last step of a CT chest because you're thinking ectopic ACTH producing tumor, and those are usually in the lung. So I just want to thank you for watching my video. You've reached the end. More videos coming this week. Please subscribe if you haven't.